Okay, Chapter 36. Chapter 36 is Geriatric Emergencies. As I've mentioned before, geriatric emergencies, or the geriatric population actually, is the primary users of EMS services. It's the number one patient population range that we deal with. Most of what we've covered throughout the course so far pertains to the geriatric population. There are just a certain few number of points that we want to retouch or maybe make you aware of in this chapter to make sure that they're reinforced at least, and see that there are some changes between your typical adult patient and your geriatrics. So there's just a couple of quick objectives in your text on 930. A couple multimedia slides regarding Alzheimer's and elder abuse. And our core concepts are going to include looking at some of these age-related changes, communication, assessing, caring, and then the illness and injury patterns that we see in the elderly. Okay, so some age-related changes. There are lots of these listed in the text, and I would like to point them out to you on particularly pages 932 through 934. Really kind of points out a lot of these. A couple highlights here that they have. After age 30, generally people are considered to be have bumped over the top of their maximum efficiency in their prime condition of their body, and they then start to degenerate. And so they say that in many cases, a person after the age of 30 loses 1% of their body function per year. So by the age of 65, that would put you down to about 65%. So you're roughly 2/3 of what you were in your prime. In most cases, the maximum heart rate is going to begin to decline. Older patients with internal bleeding may not have that rapid heart rate that you would expect, particularly those that are on a beta blocker or certain other types of medications for their blood pressure and their heart may not allow them to get that high. So we may not see that tachycardia in shock. A few of the other things to look at when we are looking at age-related changes, obviously people start to get more lines and wrinkles from the breakdown of the collagen and elastin in their skin. Skin is not as thick and flexible as it used to be. Melanocytes start to die out in the roots of the hairs, and you start to get gray hair. Demineralization of the bone starts to break down a bit, and people start to become a little bit more either arthritic or start to have some postural changes. Muscle mass generally decreases because patients are not they're not usually working as hard as they were when they were kids. They're not playing as hard or working as hard. And then loss of central nervous system neurons, we start to see decreases in all of the senses. So sight included, some senses of smell and whatnot. Cardiovascular-wise, the heart's starting to break down a little bit. Conduction system starts to wear, and the valves start to wear a little bit, so it doesn't function quite as efficiently as it used to. In most cases, particularly here in America, we have our youth catching up with us when we didn't watch what we eat, and we weren't necessarily so concerned with our diet and whatnot to prevent cardiovascular effects. It starts to catch up. Respiratory system, you have some decrease in elasticity of the lungs. Perhaps cough reflexes are starting to break down as well. So you can start to see things such as COPDs come about, a lot more patients susceptible to pneumonias. Digestive tract starts to slow. It's not quite as efficient as it used to be. Doesn't digest things quite as easily, so things that people ate early in life maybe don't agree with them so well anymore. Constipation and bowel obstructions become potential issues. start to see the linings of the intestines start to break down a bit, and run the risk for cancers, GI bleeds, and so on and so forth. The liver and kidneys aren't doing as good of a job filtering things out. So, and typically their patients, elderly patients, are on more medications, and therefore they have a greater responsibility, actually. Nice to see some drug toxicity issues or liver problems. Thyroid function starts to decrease, so they have problems maintaining their metabolism and temperature regulation. Pancreas maybe isn't functioning so well, so they start to look at some early or some adult onset diabetes. Muscle masses start to shrink up a bit, and bone mass is starting to break apart, so it's harder for patients to do as much of the activities as they used to do, as well as affects their ability to create extra heat. They may run the risk of fractures. Nervous system's breaking down, including all the senses, like I mentioned. May take a little longer for them to process certain things. Integumentary system, we've already talked about the skin starting to become fairly thin and may become easily bruised or torn. Other communication issues that we deal with, changes in hearing and vision, and potentially memory, loss of teeth, loss of brain function, Alzheimer's type diseases starting to set in, and then first assume altered mental status as a result of a present illness or injury. So if you have somebody who you aren't familiar with and you're trying to communicate with them and they're just not making any sense, there's confusion and whatnot, assume initially that that is a new onset thing. Gather more information, try to determine whether or not this is actually truly new, or is this something that this person deals with on a chronic basis. So when we have these older patients that we're having a hard time communicating with, it's real easy to get stuck in a rut with your older patients of instantly raising your voice the moment that you come in contact with an elderly person, and realize that not all of them have bad hearing. I've had bad hearing my entire life, so a lot of times I'm asking people to repeat. I'm just in my early 40s, but so vision, again, vision, some people have perfect vision, but in most cases the elderly population have some sort of a visual disturbance. And then memory. I mean, as we age, we're just not as sharp as we used to be. All right, so some history and some assessment of the older adult. Of course, our scene size up and scene safety is important. Things that you can pay attention to in some of these people's homes. Does the house look like it's well tended to? Is the house in bad shape? Is it hot? Is it cold? Is it extra humid in there? Sometimes these patients just don't pick up on this. Sometimes patients also have to make sacrifices, and they say, well, I can't turn my air on because I need to buy my medications, or I can't afford food, so I end up buying pet food. So those are things you can pick up on from being observant when you come into a geriatric patient's home. Your primary assessment, of course, you're going to still do your same general impression, mental status, checking the airway, breathing, circulation, and identifying any priority patients. And then, of course, our secondary assessment, we're going to include history and the appropriate physical exam. Remember, history can be difficult. So remember that they may be on so many medications that they don't even know. So you may have to be looking for lists, looking for pill bottles. You may have a bunch of pills in a pill sorter, and the pill sorter is not marked. So that could be a source of extra stress on you to try to determine what are the medications that we're dealing with. Patients sometimes are going to respond very slowly to your questions, maybe because they're depressed, maybe simply because memory and concentration, their cognitive abilities are starting to slip a bit. So, like I mentioned, scene size up. Be looking at the condition of the residence. Is there food in the house? Dirty or clean? Is it warm or is it cold? Are there things left out that the patient can trip on? Is the house in poor repair? Maybe that patient just can't afford to have some repairs done, and it puts them at risk. You maybe can step in here and work towards prevention by helping them out a little bit, securing something, trying to help them get in contact with somebody who can help them fix their home. So taking a look at it and seeing, hey, what can I gather from what I'm seeing here? Is there garbage in the house? Sometimes they don't have the ability to take the garbage out. I know of a case in which there was a patient, elderly patient, obviously had some considerable mental problems as well, but didn't have running water or sewer in their home, and were going to the bathroom in a bucket with a lid, and once the bucket was full, they just put the lid on and put it elsewhere in the house, got a new bucket. And you know, that's stuff that's just not safe for people to be exposed to. So, primary assessment, this really doesn't change. This doesn't change much for us. Remember, general impression, we may need to think a little bit about what we're seeing. Mental status, is she confused? Well, maybe she is confused, but maybe that's normal confusion. Airway and breathing. Well, respirators are about 22 or 24. Is that normal for the patient? Just because you maybe don't meet that ideal doesn't automatically, in most cases, throw you into a serious situation. So identifying priority patients. This is trying to find, determine, is this patient somebody who needs to get to the hospital quickly? And this, a lot of this doesn't change. Problems with respiration, patients that are unconscious, patients with severe pain, patients that are suspected of being in shock. Those things, of course, we still consider to be priority patients. So secondary assessment, take the time you need to get the full information. Talk to multiple sources. Gather clues from the home. Try to find out if the patient's being compliant. Ask them, okay, I see that you have these medications here. When was the last time you took them? Have you been using your puffers? Have you been using your nebulizers? I see you have oxygen in the house. When are you supposed to be wearing that? Well, I just don't like to wear it. Physical exam. Understand that the physical exam may have to modify a little bit because patients' bodies have changed over time. The way that we treat the patient, maybe if we're going to mobilize somebody, understanding they have a big hump back, a kyphosis, we may have to alter the way that we do some immobilization to meet the needs of the patient. And of course our baseline vital signs. Not much of this changes. So components of the physical exam when we're looking at head, neck, chest, abdomen, pelvis, extremities, and the spine. Just remember, as things change, we have stiff necks, stiff joints, changes in the sides of the chest, curvatures in the spine. We may have some arthritises that cause limitations in movement. We may not have good strong pulses, circulation in the extremities, lungs that maybe are not doing quite an efficient job anymore. We don't get great lung sounds. Just real quickly to point this out, if you've never seen the condition that's pictured here, this is a example of a patient with shingles. You may have heard of shingles before. It's the herpes virus. But what shingles does is it attacks and it affects a nerve tract. And there's something called a dermatome. We didn't really cover it. Not really important in most cases to EMTs, but dermatome, or the dermatome map, shows what nerves affect or really feed and sense certain areas of the body. And in a dermatome, the dermatome basically is little bands that kind of cover the entire body. If you look at, if you have a moment to look up dermatome, it's D-E-R-M-A-T-O-M-E, dermatome, the dermatome map. And actually, if it is in your textbook, it's on page 764 in your textbook. It shows you the dermatome map. So that dermatome map will show you that that is the specific nerve that is being affected by the herpes virus. So in this case, I'd say it's probably pretty safe to say that T6 is probably the offended nerve here. If you look at considering the dermatome map, and where this is on his chest, probably the sixth thoracic vertebrae, this nerve that comes out from that area, is being attacked by the herpes virus. And so it causes this really oddly band shape of these raised welts that are intensely, ridiculously painful from what I've heard. I've never had shingles, but I've known several people that have, and nearly debilitatingly painful. So it's interesting to look at that and note that, and knowing that you can almost perfectly pinpoint the nerve. Hip and pelvis. Remember, hip and femur fractures are very common in the elderly population. A lot of times we get called to falls and say, oh yeah, fell down and broke their hip, when in reality many of the elderly population break their hip and then fall down. Just a little bit of an odd step, a little bit of a twist in it, and snaps the femoral neck off, and they fall down. They may not even realize that it actually broke before they fell, and sometimes it is. They fell and they broke their hip, or they fell and they broke their pelvis. But that weakening of those bones can cause injuries significantly from simple falls. Spine, very commonly injured in motor vehicle collisions. The abnormal curvatures they get can make immobilization really challenging. Have to do a lot of padding, pad those voids, extra, maybe even using a pillow when you're mobilizing somebody on a backboard, which would not be normal in most cases, but we have to build up. We can't lay them flat. We can't stretch them out. So, all right, don't forget to do a good reassessment. Good reassessment helps us to make sure we're either doing our job and things are going the direction we want them to, or that we need to maybe change things up a little bit. So don't forget, reassessing all of our primary or initial things such as mental status, ABCs, reassessing vital signs, and any of the treatments that we've done. All right, so move on to a little bit more critical stuff here in a second, or new stuff, I should say. What is common, or what's commonly seen when assessing an elderly patient's blood pressure? In most cases, the elderly have significant increases in blood pressure. I mean, that's fairly common, particularly in the United States, that we see rises in blood pressure. So you may now start to see systolic blood pressures over 150 and diastolic blood pressures over 90. What is commonly fractured what's most commonly fractured in female elderly patients, and that is the hip. Elderly female patients have osteoporosis, and that osteoporosis, men get it as well, but it's more prevalent in women. Because that's a weight-bearing joint, and the way that that joint is structured, where the weight doesn't actually directly come down on the femur, it indirectly transfers via the neck of the femur, makes it that much easier to break. And then some of the challenges in immobilization. Just simple changes in the body shape, particularly kyphosis or curvature of the spine. So illness or injury in the older patient. The elderly patients are prone to some changes because of their age. Problems present differently than in younger patients. Some may be very vague signs or symptoms. Remember, we're breaking down the nervous system. The nervous system doesn't function as well as it used to, so they may not fully feel the same pain that a younger person would. They might not fully feel the limitations that they would as a younger person. A lot of elderly patients are on medication, and some of the medications have side effects. Unfortunately, there's a large national health system that takes care of a lot of our former military that tends to have patients on extremely large amounts of medications, and sometimes they're on medications because they're trying to counteract the side effects of a different medication. Unfortunately, it seems to be very common in that system, but there can be some drug-patient interactions and some drug-drug interactions. Sometimes we have multiple doctors that we're seeing. You might see a family practice doctor or a general practitioner, and maybe you see a pulmonologist for your lungs and a cardiologist for your heart, and a nephrologist for your kidneys, and they're all having on some different medications. And if you're not fully honest with them and spill all the beans, and your doctors aren't able to communicate, you could end up on medications that end up interfering with other medications. Shortness of breath. As we've mentioned, there are plenty of cases in which patients are calling us for shortness of breath. It's the number one thing we're called for. In many cases, it's due to congestive heart failure or COPD. In those cases, a lot of times we do find patients, as is pictured here, on home oxygen. Maybe they have lots of puffers, they have inhalers, they may have nebulizers, but the shortness of breath certainly a very, very common thing. Now, interestingly enough, you see that this lady has about 9 miles of nasal cannula resting on her oxygen concentrator there, and you may not be familiar with that, but the little kind of putty gray colored device right here in the front of the picture with the green tubing wrapped around it is an oxygen concentrator, where instead of using a steel or an aluminum bottle, this machine actually concentrates, pulls oxygen out of the air, and keeps it while it blows the rest of the room air or atmospheric air back on out, and it feeds the patient oxygen. So she's got this nasal cannula all wrapped up there, hanging on the side of it in the green tubing. A lot of times those are multiple joints, and the joint may come apart. Sometimes you've got so much tubing so you can walk all over your house with your nasal cannula on that a patient starts to become short of breath. They get a little freaked out. They call 911. We show up. We go starting to check everything, and we go track down the end of their oxygen tubing. Come to find out it came off of the concentrator or the bottle or whatever. So sometimes it's really kind of silly stuff, but it's something that we would consider. One more thing about shortness of breath is shortness of breath sometimes is the only sign or symptom of a heart attack that some of our elderly population deals with. Chest pain, the complaint of chest pain can come from lots of different conditions, whether that's pneumonias or rib fractures, aneurysms, heart attacks, and so on and so forth. Remember that there's plenty of things that can cause this. Even that guy that we saw with the shingles would be complaining of chest pain if we didn't stop to take a moment to really look at this situation and understand, well, that's not cardiac-related chest pain. That's actually it's a nervous pain, nervous system pain, so as opposed to being heart nature. So lots of different things that can potentially cause chest pain. Remember, a tearing-like sensation of pain is usually a bad sign. Usually means that there is an aneurysm that is rupturing or starting to tear or rupture. Altered mental status, all too common in the elderly population. Remember, it can be anything from medications, hypoglycemia, could be a stroke, maybe certain just medications that they're on. It can be hyperthermia, pneumonia, infections. There's lots of different things that can cause altered mental status. Abdominal pain and GI bleed. A lot of elderly population suffer from gastrointestinal bleeds or GI bleeds, and these are conditions which cause some abdominal pain. May not show up as pain, may just come out as kind of a cramping, maybe just bleeding eventually. Could be dark tarry stools, could be vomiting blood. So ask the patients if they're complaining of anything to do with the abdominal area. Bowel habits, bladder habits, keep digging. Ask them, have you ever heard of an aneurysm? Diverticulosis or diverticulitis, where you get little inflammation pockets along your intestines. Also, people with abdominal pain, the elderly in particular with abdominal pain, may also be having a heart attack. And they complain of it as an abdominal pain as opposed to chest pain. Dizziness, weakness, and malaise. Malaise is just kind of generally feeling tired and worn out. Don't take these complaints lightly. They can be associated with lots of things. A lot of times it actually has to do with their heart or some medications that are probably heart related as well. They can be life-threatening. You just got to keep an eye on them. And even these vague symptoms that we would commonly think, gosh, why did you call me for this? Well, with a little bit more digging and doing a good assessment, you may actually turn up something that's kind of actually a big deal. So a heart rate of 150, 160, 180, 200, they might call you and they may not realize that it's their heart. Boy, I'm awful weak, and every time I stand up I feel like I'm going to pass out. Well, that sounds pretty ridiculous to be calling an ambulance for, but come to find out, we show up and we start taking a pulse, and here's this pulse. It's almost so high we can't count it, and their blood pressure is 70/40. Oh, well, how about that? And all we had was weakness and dizziness. Depression and suicide, very common in the elderly. A lot of times loss of a family member, loss of their friends, they're retired, they feel like they're kind of a burden. In many cases, the elderly person has recently come down with a serious health problem that's potentially going to be lethal. And so those are some different things that will start to cause some depression in our elderly population. They just feel like they're kind of a burden, and in many cases think, oh well, it'd be better for me to take myself out of this picture than to have everybody else have to worry about me. Shingles, I told you about that shingles picture that we had there. It's a virus that basically lays dormant for a lot of time, appears like a belt band around the torso in most cases, and scab over, very painful. You can contract it from touching the fluid, so BSI is very, very important. Falls, death can result. Falls are actually a very, very high cause of death in the elderly population. They may have bruised ribs, they may break some ribs, their ribs hurt, so they don't take deep breaths, they develop a pneumonia, and the pneumonia ends up killing them, although it all started out from a fall. May indicate that there's another serious health problem. Maybe that person called us for dizziness and weakness with a blood pressure of 70/40 and the heart rate of 200. Now all of a sudden they pass out and they fall and they hurt themselves. And we got called for a fall, but come to find out, oh, look at this, all this is out of whack. So, and then assess for the cause of the falls as well as the injuries. So try to figure out what caused it. Don't okay, I see that you've fallen. Why did you fall? Don't assume it was because they tripped or they missed a step. It may have been something else. Weakness, tiredness, blacked out, whatever. Sadly, elder abuse, neglect is a reality that we have to deal with. A lot of times, unscrupulous people find that, hey, I'm going to get some money if I have to take care of my elderly parent, but you know what, I don't really want to take care of them, but since I'm getting a check, we'll just put them here in this back room. We'll check on them once a day, make sure they're okay. They're fine. So there can be that financial side of it. Sometimes people just get so fed up and sick of taking care of their loved one, their parent, that they kind of lose it and they stop doing what they need to be doing, or they can be physically abusive towards them. Occasionally we hear about odd situations occurring in nursing homes, whether it's neglect or abuse or even sexual abuse. The elderly are very, very concerned with loss of independence. You hear a lot, the kids that have to end up taking their parents' car keys away, or they surrender their license, or they have to move them to an assisted living. This is a big deal to people. I mean, most of us these days, we cherish our independence, and to think of, now I can't do it all on my own. So remember to try to treat your patient with dignity. Don't use those cute little catchphrases like honey and dear. That's demeaning. Mr. or Mrs., unless they tell you to call them otherwise. Don't minimize their fears or concerns. You can try to converse with them about them, try to help them feel a little more comfortable about the situation, but don't minimize them. If they want you to lock up their house, take care of their pets, turn off their lights, that's all important things to them, because they are really stressing over this. They may never come home again, and that's what they honestly think. So be reassuring and empathetic. So something to think about. What are some important facts to remember when treating the elderly patients? Not only do we have changes in physical condition, but mental condition, communication facts, and then there's a lot of other psychosocial issues that come into play. What are the best preventative measures for an EMT who comes into contact with shingles? Gloves, hand washing. Don't touch anything else with the dirty gloves that you may have touched their wounds with. And then what is a side effect of NSAID use? So NSAID use is non-steroidal anti-inflammatory drug, or a lot of times what we refer to as Tylenol or ibuprofen. But these non-steroidal drugs often have significant side effects with increased bleeding. So people take a lot of, say, naproxen or ibuprofen. They can have some serious issues with prolonged bleeding or internal bleeding. So there's a little video about Alzheimer's disease and elder abuse. Both would be worth your while to take a look at. So our chapter review. Despite your generalizations, older people are individuals who can differ significantly in their health needs. No two people are alike. We tend to see some trends, but we certainly have those people that buck the trends as well. Prevalence of many diseases increases with age, increasing the portion of the older population that requires health care. Most of the people who are using our healthcare system in the United States are the elderly population. We live a lot longer than we used to live. Age-related declines in body system functions are going to change our response to illness or injury, how we heal to illness and injury, and any treatments that we receive. Multiple medical problems can really make things very unpredictable, can make things very complicated. If we have a patient, if we're dealing with a 20-year-old diabetic patient, things in many cases, in many situations, are going to be fairly straightforward. But we've got now the 75-year-old that's got diabetes and heart problems and had a prior stroke and has a history of Parkinson's disease and glaucoma and it just continues to make it a bigger and bigger ball. Nervous system changes along with isolation, financial problems, loss of loved ones, chronic health problems, increase the risk for depression in the elderly, very high rate of suicides, and this can interfere with that person's ability to care for themselves and to communicate. Aging produces some common body changes with different impacts on different patients, and evaluate your older patients individually. In some cases, the EMT must adapt their assessment and treatment to account for these things. Medication difficulties are common keep that in mind. Sometimes it's very confusing. Sometimes they even forget that they took their medication. They overdose themselves unintentionally. Elderly abuse is far too common of a problem. We've got to be diligent for that. And again, remember, just as in the child, our goal is getting this patient taken care of, transported to an appropriate facility where they can be cared for, and then working to report all of our suspicions. So some questions to consider. What size blood pressure cuff might be better suited to an elderly patient? Remember, a lot of elderly patients have become smaller than they were before, so you may need to even consider using a child-size cuff. I've had to use child cuffs on many of older, particularly ladies, but even men in some cases. What challenges might you encounter when assessing the mental status of an elderly patient? They may have a pre-existing condition that makes it more difficult for them to respond in a quick manner. They may not fully understand what you're asking. All right, you're called to a nursing facility for an 85-year-old female with trouble breathing, very confused. What do you suspect may be wrong with this patient, and what actions would you take in treating this patient? Well, you're called to a nursing facility for an 85-year-old female. The confusion may or may not be new. That's something we need to assess from the staff. And the trouble breathing. Is the patient truly having difficulty breathing, or is this something perceived by the staff? So this is really something that we need to chat with the staff there and say, tell me what this patient's like on a normal basis. If the confusion is new, then that obviously, along with the difficulty breathing, becomes a couple of priorities in our assessment and treatment chain. However, if the confusion is a frequent thing, they have a chronic problem with confusion, then we really gear our assessment and our treatment towards the difficulty in breathing.